They understand what it's going to do to those around them. There's no way to help someone who really wants to kill himself. Well, we know that's not true. Suicide hotline. Now there's so many available resources, whether it's actually being hospitalized or telehealth. Mention of the word suicide will cause suicidal individual to actually commit suicide. No, you have to ask them. Are you thinking of committing suicide? You have to ask them. Ignoring verbal threat of suicide or challenging to carry out suicide plan will reduce individuals' use of these behaviors. You should never challenge a person to carry out a plan. Okay, this isn't a game, right? People who talk about suicide are only trying to get attention. It's a cry for help. It's not, attention. It's a cry for help. Please help me. I'm talking about it because I'm feeling down. Okay? This is a very deep topic that's not spoken of a lot, but it should be. Risk factors. So many risk factors, right? Females were more likely to attempt, but not actually commit it. Teens, middle, and older adult males are more likely to commit suicide. Okay, with older adult clients, they're at higher risk if they have untreated depression or they're not properly diagnosed and they're diagnosed with dementia instead of depression. Loss of employment, loss of a job, finances, issues at home, family problems, feeling powerless in whatever situation you're in. Okay, isolated, prior attempt obviously increases your chances. Okay, alcohol abuse, substance abuse, death in the family increases your chances. Okay, statistically, according to a test book and statistically, right, American Indian and Alaskan Native ethnic groups are highest rate. So this is because of where they live also, and culturally it's often not spoken of. Okay, and obviously if you have firearms or if you have immediate access to the means of how you're going to go through with it, increase your risk factor, right? Increase chance. Okay, I'm not going to touch on so much when it comes to this, but the statistic ranked 10th cause of death in the US in 2014. Every 12.93 minutes there is a suicide. I actually think the statistic it's sooner. I don't think that's the right one, but that was at a certain year. That was the statistic. So during our break, if you really want to think about how deep this goes, during that 15-minute that we had, someone committed suicide. It's very, very deep and upsetting. Individuals ages 85 older, largest number of people who died 2014. Look at that. Highest group are individuals 45 to 65. Sometimes, midlife crisis hits, whatever issue occurs, and then during that time, you gotta understand so many things happen. Your children are, what is it, emptiness syndrome? That happens, right? Maybe, and then a lot of other environmental stressors. So that age group highest at risk because everything can happen during that time. Okay. I'm not going to dive deep into the biological factors. I don't focus on it, and neither does your proctor. Low serotonin levels are related to depressed mood. We just talked about it. Right? I do not dive deep into this. I care about. Right? Freud believed. This one says 120 die per minute, so that's the right statistic. Thank you. I'll fix it on my slide. Can you believe that? Can you imagine this? How insane this is. Is it reported? No. Do people get help? It's just, it's horrible. I'm taking this personally. Freud, aggression turned inward. That's his belief of how suicidal behavior works. Inward aggression, right? Aggression, directed inside towards how you feel, think, wish to kill, wish to be killed, wish to die. It's called suicidal hostility. It's quite common theory. I'm not going to dive into it. Ehrenbeck's central emotional factor is hopelessness. Main nursing diagnosis, hopelessness. For those who have SI and depression, diathesis stress model. That's the one I love. Combination of nature versus nurture. And then copycat suicide. Japan has a suicide social media. Interesting. I did not know that. Oh my gosh. I'm gonna look into that. That is no way. That's horrible. And I'm assuming their government or whatever department of mental health doesn't navigate it, huh? Unfreaking believable. Wow. Copycat suicide. This is where social media comes into play. There you go. I think 13 Reasons Why played a huge role on adolescent suicide rates. Um, it romanticized the idea of suicide. I think later on they even removed that scene from the show, right? I'm not sure, but it was really triggering. It was a huge deal. But that's what social media does. Influence of the media, romanticizing this idea. Hey, look how this looks. It was horrible. I thought it was disgusting how it was made. And I loved the book. We're in agreement with this, right? It's a horrible thing. Now, our goal when we do care for our SI patients is to develop these protective factors, skills in problem solving, coping, conflict resolution, right? Cognitive behavioral therapy. And in single therapy, let's develop strong family and community support. Let's, belonging, sense of identity. This is where cognitive behavioral therapy comes into play again. Future goals, right? You have any activities, you have access to healthcare, mental health care, physical help, right? All of that. Accessible to a variety of clinical interventions and support for seeking help. So, is there meaning in your life? Do you have resources? So, those who have all of this, right, decreased chance of SI. And then when our patient comes in and we care for them, this is what we want to establish. Okay, upon discharge, after discharge, this is our goal. Okay. Oops. Okay. So assessment. We know this already. It should be engraved in our heads. Patient comes in. MDD is the diagnosis. As for SI, do you have a plan to harm yourself? They say yes. The next thing you're gonna do, please tell me a detailed plan. Tell me how you're gonna do it. Okay. Tell me how you're gonna do it. Ask directly. Do you have a plan and time? Yes. Ask directly if she thinks of suicide. This will not trigger them one bit. This is your job. For 7 cups, that's what you should be doing, right? If someone is suicidal. Comments of suicide are made to someone the patient thinks is supportive. So develop that nurse-patient relationship, right? Assess for, and then you're going to use what? Columbia rating scale. Then there's also a sad person scale. You're going to utilize some form of assessment tool. They will always tell you. They will always tell you if they have an SI. Always. All of my patients always say, yes, I have a plan to commit suicide. I've never had a no on the unit. No one's ever said no to me. Now, we got to be very observant. Comments can be direct or indirect. So covert, okay? Covert or overt. It's supposed to be a T, okay? So direct is very to the face, to the point. There is just no reason for me to go on living. I can't do this anymore. It's not worth it, okay? Indirect is everything is looking pretty grim for me, okay? There is no hope for me in doing this anymore, okay? Very passive, okay? And then for the last 2 bullet points, is very, very important to understand this, okay? So, we just learned about a bunch of meds, okay? We learned about a bunch of meds, all their side effects, and they're supposed to kick in hopefully like 4 to 6 weeks. That's the best time frame. Maybe even more, assuming they work or they don't. If your patient comes in and they have all these signs and symptoms of depression, you start them on meds, and then by the end of the week, they seem happier, they're talking to everyone, they're participating, Maybe they're writing something, like a lot. They're giving away their favorite stuff. This doesn't mean that the meds have worked. The meds will not work in 1 week. This means they have all this energy to go through with their plan. So you better watch out. Okay, those are indications of suicide. Absolutely. You better watch out. Do not remove that one-to-one. Keep them close to the nurse's station. Okay? If they're getting their affairs in order, they're writing, look at what they're writing. Read it. Look through their stuff. Look through all of their stuff, all of their belongings. Um, do not leave them alone. They have all this energy to go through with it. Okay, this is part of your assessment. Okay? Isn't it interesting? It's so gnarly. Now, assess suicide plan, right? Does the patient have a plan? Okay, yes, right? How lethal is it? Can the client describe it? Let them describe every single little detail. Have them have them actually um, have them actually describe every detail, every single part of the plan, because you want to make sure you assess them thoroughly. Does the client have access to the intended method? Has the client's mood changed? We just went over that. Okay. Has the client's mood changed? A sudden change in mood from sad, depressed to happy? All of these are indications. Okay. It's a very, very sad topic. Very. And I thank you guys for being so resilient in it. It's a very triggering topic for everybody. Okay. Thank you guys. Seriously. Props to you guys. Have I told you guys the story of the patient? We walked in, the nurse refused to do an assessment and like walk into the patient's room. I was charge nurse that night and I had so much going on. We had a seizure on the unit. So I was charge nurse, I was doing my due diligence and taking care of it. And then we finally assessed the one patient that one of the nurses wasn't being a good nurse. She wasn't being a good nurse, wasn't assessing. We walk in and he has the belt of his bathrobe and he's choking himself. Can you guys believe it? This is why you should always assess your patient. Okay? It took 9 huge males to get that belt away from him. And then, he somehow had a plastic fork, those like plastic, what is it, spork? He broke it on the table and he was going towards his neck. This is how important it is. It's a very triggering topic, but I think we need to be very vigilant about this because this can happen even on a med-surg floor. Even on a med-surg floor. It's horrible, horrible. Always be vigilant, always. Take that extra 5 minutes to go check up on your patient. Physical assessment. What I always do when my patient comes in and I do a skin check, this is what I look for. This is going to give me an idea if this patient had a past history. Any lacerations, scratches, healed marks, healed scars. Okay, this is what I look for, always. Always, always. This is what you're inspecting for. This is in your book too, right? Highly lethal methods, less lethal methods, right? Risk cutting, house gas, non-prescription meds, tranquilizers, and highly, right? These are the ones that cause, they're highly lethal. Gun, jumping, hanging, drowning, all of this, car crash, exposure to extreme cold, okay? It's good to know these. They can pop up on your proctor somehow, or so I've heard, okay? I'm not gonna go over this again, but study these questions. When you're studying for Columbia Suicide Rating Scale, utilize the handout that I posted on Canvas. That's a better way, okay? I don't dive deep into levels of intervention. Primary, secondary, tertiary. Primary is we're educating them, okay? Educate to prevent suicide. Give them information. Let them know. I do ask them about it. So if I see scars from a previous wrist cut, I say, hey, I noticed that you have a cut on your wrist. I see a few of them. Can you please tell me more about this so we can take care of you better? And they will always tell me. Always. Always. This is why like nurse-patient relationship is so important. When you first meet your patient, Be very caring. Set that boundary. Let them know that you are there for them no matter what, right? Obviously, tell them the rules, no blur boundaries. In psych, they're so vulnerable. You develop that trust, they will tell you everything about them so you can care for them well, right? Secondary is treatment of the actual like suicide precaution. Maybe they're on the 5150 here, right? And tertiary, support and assistance. Okay, it's already happened. Okay, intervention with a circle of survivors left by individual who completed suicide to reduce traumatic aftermath. Support for family members, right? For those around them, for friends and family of the loved one. Okay, again, verbatim, I feel like a broken record. I've been saying this, but it's because it's going to pop up. Ask the patient, have you thought about harming yourself? Assess the plan if they say yes. 1-to-1 immediately. Do not assign to a private room ever. Close to the nurse's station with a roommate. Okay? Search all of their belongings. All of it. They should not be having any of these with them. It's with you. Okay? They take a shower, you're with the sitter is with them. They shave, the sitter watches them. They want to brush their hair, the sitter watches them. They want to use their perfume, the sitter watches them use the perfume. Everything needs to be, you walk into that patient's room and you examine everything, okay? You give them utensils to eat, make sure you get the same ones back. You know the bra wires, we remove them. Shoelaces, we remove them, okay? Hair ties, we remove them, okay? All these things. And remember, when you're giving them meds, nope, no independence whatsoever. No time for privacy. You do not leave them alone. Safety. You can give them the brush and they can do it themselves. That's a form of independence. But shaving, you watch them shave. Remember, it's a razor. You give it to them, watch them shave. It's safety. Safety. You would not do it. If there's an active SI and they're on a hold, we would not be allowed to give it to them. Yeah, we would not be allowed to give it to them. Now, I'm just saying, watch out for razors, because what happens is they bring in shampoo bottles with them, and instead of it having liquid, they have razors stuck inside. So check all of their belongings, okay? Sometimes what the doctor does with the patient, they're like, hey, like, I'm allowing you to shave your beard if you're a guy, whatever, but these are the parameters. The doctor sets it with them. You watch them do it, and you stay really close in case something happens. Now, if it's an extreme situation, that's not allowed. They're not allowed. If they're on an active hold, does that make sense what I'm trying to say? So there's literally no area for autonomy here. Rigid, very rigid. Yeah. Especially with meds. Watch them like a hawk, hands above the covers, okay? Check their mouth, use that pen light, okay? Okay, safety plan. Verbalize, so actively suicidal patient, so if a client verbalizes clear intent to harm self and is unwilling to make a safety plan, like they're not willing to comply, blah, blah, blah. So chances are when this happens, they'll be placed on a hold, right? They'll be placed on a hold. I'm repeating this, closely observe the client swallow each dose. Hands should be at view at all times, even while they are sleeping. Because sometimes they act like they are asleep, but their hands are underneath their covers and somehow they have some form of material or whatever, or a razor, and they start to cut themselves, okay? Always watch them, okay? 1-to-1 nursing observation and maintain arm's length at all times, within sight, within close parameters at all times, takes priority, okay? Never allow the patient to use the bathroom with closed doors. Allow the patient to shave and shower. Never allow the patient to shower and shave in private, okay? Never, ever. And here's the thing, when they know someone's watching them, they usually don't do anything because they know what happens. It becomes an emergency situation. it becomes an emergency situation. And as we learned last week or the week before, sometimes we even restrain them because they become combative for safety measures. This is not utilized on the unit ever, not anymore. There used to be no suicide contracts where they would sign, hey, I will not attempt to commit suicide. That's not allowed anymore. It's not even done because the patient can break that at any moment, especially patients who are going through an active plan, right? Thinking of an active plan. Okay? So I don't care if the patient says, yeah, I'll sign a contract. Your suicidal precautions do not go out the window. Does that make sense, guys? And there's literally a lack of research on this stuff. So I don't know why some facilities actually, excuse me, what is going on? Okay. So now this is self-injurious behavior, okay, which means like cutting, right? Lacerations. So this is maladaptive and dysfunctional. We're not reaching SI yet. It's maladaptive dysfunctional measures a person uses to restore inner equilibrium, right? They're so anxious and they're stressed out. They don't know how to cope. It's a maladaptive measure. So they'll start to cut themselves. Okay, self-injurious behavior involving deliberate infliction, physical act on one's own body without intent to actually die, without the intent to actually kill yourself. Okay. We had a patient on the unit who would walk and fall on purpose. Okay, walk and fall on purpose. Would bump into sharp corners on purpose, and he verbalizes, "I'm doing it on purpose. I'm very anxious and doing this on purpose." Oh, done. Done with this one. Okay. What are you supposed to do in those situations for self-injurious behavior? Is that what you're saying? So assess their injury immediately. Hey, let's check it out. Let's see. Let's see if you've got any bruising. Let's see what's going on. And then